Mortality is not the only important issue. I think in this group of patients who've got advanced atrial fibrillation with advanced heart failure, I think finding any drug that can cause a substantial reduction in mortality is going to be difficult. And that's just the nature of the patients. But there are other important areas. So do these drugs improve your heart function, so ejection fraction? We don't know that yet. Do these drugs improve quality of life? We have some suggestions from observational and post hoc randomized data that it might, but we don't know that for certain, and that's why we're going forward with this trial to look for any differences that you might find, particularly in quality of life and ejection fraction. And at the end of the day, we want to find drugs that can reduce hospital admissions, because it's a huge problem for patients with heart failure and atrial fibrillation. Recurrent hospitalization is a big problem for healthcare services around the world, and if we can show that one or other drugs has a benefit, then that will be a huge step forward. I think it's important that doctors still stick to the guidelines that we have for both heart failure and atrial fibrillation. So in particular, if patients are compromised hemodynamically, to think about rhythm control. There are some avenues that certain selected patients might benefit from ablation therapies, which are invasive, but in a certain small group of patients they may be beneficial. Then there's the whole range of drugs for heart failure, so things like ACE inhibitors and angiotensin receptor blockers, diuretics to improve symptoms, mineralocorticoid, sort of aldosterone antagonists, which are important. Again, the data for their use in patients who've got concomitant atrial fibrillation is weak, but I still think there's an important need for those patients to be on those treatments based on the subgroup data that we have available. So I think there's still a lot we need to do with these patients. There's also other heart failure advanced treatments like resynchronization therapy, defibrillators, and I think the important thing is that until we know from randomized trials about these sorts of drugs that we continue with the guidelines that we have from groups like the European Society of Cardiology and others. This is a good stepping stone, I think, for the trial that we're planning. We've recently heard that has been funded by the National Institute for Health Research in the UK, and so we'll be planning a smallish trial of 160 patients to first decide on whether digoxin or beta blockers has any impact on quality of life and ejection fraction, and importantly also to decide how we measure those things, because although those are some of our important tools that we use in clinical practice, as yet we have no trial data about how we should do those in clinical practice. So it's a sort of a fact-finding mission first off to find out what we need to do, and then the plan in the long term would be to look at a much larger trial that would hopefully be powered to look at the difference in hospitalization between these sorts of drugs.